Okay, thank you guys for all duking it out till the very end of the Mellinkoff Symposium. My name is Jenny Sauk. I'm the Director of IBD Clinical Care here at UCLA. So I'd like to take a few moments and introduce our panelists today. We're very lucky to have a wonderful panel here, and I think this will be a very interesting session. So we have Dr. Ray Cross here. He's Professor of Medicine, Director of the IBD Program, and Co-Director of the Digestive Health Center at the University of Maryland Medical Center. And we have Dr. David Rubin. He's the Joseph B. Kirshner Professor of Medicine and Chief of the Section of Gastroenterology, Hepatology, and Nutrition at the University of Chicago, as well as a long-term mentor of mine since medical school. So very happy to have you guys here. So especially happy since I know there's been so much national chaos going on, and we really appreciate you both coming. And I think you'll add a lot of extra dimension to our cases today, so thank you. And then we have our local IBD leads. We have Dr. Berkeley Limketkai. He's our Associate Clinical Professor, as well as a Director of Clinical Research for the IBD Center, and we're lucky to have him here. He came from Stanford, so we're very excited about that. And we have Dr. Mona Rezapour. She's our Instructor of Medicine. She completed her IBD Fellowship at the University of Miami, and she's a community practice IBD lead physician practicing out of West Hills. So today we're very excited to have them here, and the usual format of these sessions is that we have case-based sessions where we have audience participation. We're going to have panel discussions and mini lectures embedded within the cases. First, we're going to have Dr. David Rubin give us some introduction about what's new and notable in IBD in 2020. So we'll start with that first.
Okay. Well, good afternoon. Thank you very much for staying. I thought that last session was fabulous. So deep breaths. We're going to enter the IBD session now. Can you have my slides up, please? Do I have to just click? Thank you. All right. Well, I'm delighted to be here, and there was no one wearing a mask on my plane, and the guy next to me only sneezed once, so I think we're all okay. I do have disclosures. I want to make it clear this is a CME presentation. It's been reviewed appropriately, and of course I have conflicts, but all of these slides and my comments are my own, and I take full responsibility for them. So new and notable in 2020. Well, first of all, there have been some guidelines published, and this isn't just, of course, in the last 2 or 3 months. These go back a couple years, but I did want to point out to you that the American College of Gastroenterology published a new guideline on managing ulcerative colitis, and I was part of that with a great group of folks. But the AGA also published guidelines related to mild to moderate ulcerative colitis and more recently moderate to severe ulcerative colitis. And we've had some other statements that have come out. And of course, everyone in the room is quite aware that there's been a lot of discussion about coronavirus. So at least we can mention it here, and I'm sure there may be some questions from the room. But if you want to read the latest, just today we posted a statement from the International Organization of IBD. You can either go to ioibd.org to read those recommendations for your IBD patients, or if you're already following on Twitter, it was tweeted out by multiple of us and retweeted. So I encourage you to stay up to date. Bottom line with corona, just to get that started, is that we are recommending patients stay on their therapies. It's very interesting that the ACE2 receptor expressed on cells is actually expressed on enterocytes, among other places in our bodies. And when you're inflamed, you actually have upregulation of that receptor, and it may lead to more entry of viruses into the body. There's also some interesting data in ongoing studies right now that anti-cytokine therapies may reduce complications from the coronavirus 19. So staying on your therapy may not only keep you in remission, of course, and keep you well from your IBD, but may prevent entry or complications from the virus. So the current recommendation to your patients, stay on your therapy. Steroids are worse, flaring from your disease are worse, and obviously the usual precautions for hand hygiene and other things. And we can talk more about that. Here are the topics I'm going to cover. There's a little bit more in your syllabus, but I had to cut it down for time, and that's for you to learn a bit on your own, or certainly for our questions and answers. So one of the first things I want to point out to you is that we have had a shift in managing IBD to thinking more about how we can treat the patient in front of us at the current time, and then think about what's happening to them in the future. And that's the distinction between disease activity and disease severity. So the concept of disease activity, if you look at the red box at the bottom, it's how sick is your patient right now? How inflamed are they? What other extraintestinal manifestations may they have? What else is going on? And severity is meant to represent prognosis. what is the risk the patient's going to have problems in the future? And what's summarized here is not just several of the guidelines that I mentioned to you, but also care pathways that have been published by the AGA. And when you assess your IBD patient, you want to break it into those two components. What do I need to do right now to address the acute illness? And what am I going to do to prevent complications? And recognizing that choices of therapies actually incorporate prognosis as part of our management is a newer concept in IBD. And so what we recommend is breaking it down into that, and then you can, of course, start thinking about coexisting problems. If it's an adolescent, of course, do you have to address nutrition or growth and development? And you think about other parts of the history, like what has this patient already had that tells you a bit more about what their likelihood is for poor outcomes in the future. Recognizing this in the ACG guidelines for ulcerative colitis, we actually modified what was previously called the Modified Truelove and Witts Severity Criteria, and we now call it a UC Activity Index. And there's a few things that are incorporated here that are new. The first one is that we've acknowledged finally that endoscopic activity and inflammation of the bowel are actually part of knowing how sick your patient is. They also factor into prognosis. But believe it or not, this was not included in prior severity indices. So even though we all think of looking at colitis with our scope and knowing how inflamed they are, it had never been incorporated into an activity index like this one. We also adopted calprotectin as an acceptable measure of disease activity and something that can be used to assess your patient. You can see by the ranges that we have here that we're not so good yet at separating out mild to moderate to severe to fulminant, but we certainly recognize when calpro is less than 150 to 200 that it might be a category of remission. Also added to the activity index is something that we always ask about but was not included previously, which may be a surprise to you, urgency, which is of course very disabling for patients when they have active rectal inflammation. So that's now included here. And we added a category of remission, so the patient can have a status of being in remission among these other categories, which was not included in the past as well. So you can appreciate the way we've broken this down. From a clinical point of view and thinking about available therapies, we separated mild from moderate to severe, and we didn't call it mild to moderate anymore just because of how we think about some of our treatment options. So this is important, and that's certainly new and notable. In the severity category, thinking about prognosis, I've put down the risk factors for poor outcomes in both UC and Crohn's side by side here for you. And what we have known for some time is that there are certain risk factors that put people at risk either for surgery or repeat surgery in the case of Crohn's, or hospitalization, or disability, which is defined in many different ways, but you get the idea. In general, people diagnosed younger have an increased risk for these problems. Having required hospitalization or having a Clostridioides infection puts you at higher risk. Needing steroids is a prognostic marker. That's different than you just prescribing it, but the patient who's sick enough to need them. And you can think about those individual patients sitting in front of you. Markers of inflammation are also important. If you look on the ulcerative colitis side of this, you can appreciate that a high CRP or a low albumin puts you at higher risk for poor outcomes. And then, of course, there's the distinction between the patients who are smokers, where we've recognized for a long time that that's a risk factor for poor outcomes, but in some of the newer analyses, it falls out of the assessment. We still think it's important, obviously. And there's the observation that people who are ex-smokers and develop new ulcerative colitis may be harder to treat, although that's still evolving. So you can think about the patient in front of you in terms of their risks, and that may also enable you to have the conversation about what treatments to use. New and notable is the availability of Tofacitinib, our first novel small molecule for the treatment of moderate to severe ulcerative colitis. Summarized on this slide were the pivotal trials. 2 induction trials of 10 milligrams twice daily of Tofa, which are summarized on the left there, and then the maintenance trial, which is the second bar chart on the left, which followed patients out on either 5 or 10 milligrams twice daily. Tofacitinib inhibits an enzyme called Janus kinase. Janus kinase is an enzyme that's necessary for activation of lymphocytes and cellular transmission of environmental signals to turn on inflammation. So unlike some of our directed monoclonal antibodies, which hit one target or maybe two, this actually knocks out many targets. So even though it's a small molecule and it's oral, which is convenient, it's actually a very potent immune suppressant. And you can see that it works quite well, better than placebo, and we'll talk more about tofa in a minute. The other thing to know about this is that it increases lipids by about 10%. Within the first month, that goes up, and then it's stable. It doesn't continue to climb. In most of our young patients with IBD and with ulcerative colitis, they don't have a problem with their lipids, so this is not usually an issue. And it's also interesting that the HDL and LDL go up in a stable ratio, so the risk for cardiovascular events seems to be stable, and there have not been any reports of increased cardiovascular complications due to the lipids. I'll talk about that on the next slide a bit more. There's also a dose and duration-related increased risk of activation of herpes zoster shingles infections, mostly with 10 milligrams BID, and the risk is about 4% in the maintenance phase. It doesn't really happen in induction, which the risk is only about 1%. But that is a significant increased risk that has led in the United States to the recommendation that we vaccinate against shingles in all of our patients, regardless of their age, especially if they're going on this therapy. And we've been doing that with the killed vaccine, Shingrix, successfully, and have had good tolerance of that. Now, because the lipids go up, the FDA asked Pfizer to do a safety study, specifically to see if there were going to be any cardiovascular problems, and it was going to be targeted in a high-risk population. So older patients, which meant rheumatoid arthritis patients, those with pre-existing cardiovascular disease, and they randomized them to anti-TNF, 5 milligrams of tofa BID or 10 milligrams. And at a pre-specified interim analysis, there were no cardiovascular events, but there were unexpected pulmonary emboli in the 10 milligram BID arm and mortality associated with that. The study's not completely over yet, so we don't even have all the details about these patients. So they were older RA patients with cardiovascular disease who had these complications. It led to a change in the label in Europe and in the US with advisory to try and dose reduce in maintenance down to the 5 milligram dose when possible. And it led to the recommendation that you should screen your patients for their risk of clotting before you start them on this therapy. It also led in the US to changing where this drug can be positioned. So prior to these data coming out, the FDA had said you could use this drug without prior experience or failure of biological therapies. After these data came out, the FDA changed their mind, and they said you should use the drug after TNF failure. So you have to go through anti-TNF before you can get to tofa in your patients with colitis. Now, the paradox here is that in the clinical trials, the people who had already failed anti-TNF needed 10 milligrams twice daily in maintenance. So they're setting us up for needing people to be on the higher dose, which is the higher risk dose. I'll come back to this in a couple minutes and tell you more about it. Also new and notable was what's been billed as the first head-to-head biological trial. This was also in ulcerative colitis, and this was looking at adalimumab compared to vedolizumab in patients with moderate to severe UC. The primary endpoint was clinical remission at week 52, and in red is vedolizumab, which you can see was statistically better than adalimumab at achieving that endpoint. In the trial design, they allowed patients to have been exposed to anti-TNF previously. So we were wondering whether or not that biased the study against people who got randomized to the adalimumab arm, which is why you see the other bars here that are looking at whether the patients were TNF exposed or not, and there wasn't a significant difference. However, there was no forced steroid taper, and patients were on concomitant immunomodulators. So just my take on the Varsity trial, although it's important, is that there were some limitations. They didn't allow dose escalation, which we recognize happens in many of our patients, especially in UC. They didn't tell us, and we haven't seen serum concentrations of the drugs. And if you actually adjusted for concomitant steroids or immunomodulators, there was not a statistically significant difference between the two arms. So while this supports the general practice that we think an organ-selective therapy makes sense when you're going to a biologic in our IBD population, meaning vedolizumab, it didn't actually pan out nearly as strongly as one might have expected, so you can interpret this with some caution. Another study that I liked in the last year was this meta-analysis. We've been talking for a while about if we could just give more drug, we would get more people to respond. Well, in the hospitalized sick patient with UC, many people start with 10 milligrams per kilogram and even give a second dose within days of infliximab. Well, this meta-analysis suggests that that actually doesn't prevent colectomy. And below that, the second bullet point there are the results presented at several international meetings in which high-dose adalimumab loading in both Crohn's and UC did not have a better remission rate, both for induction and a maintenance success in Crohn's or UC. And the high-dose adalimumab was 160 milligrams weekly for 4 weeks. So if you're wondering whether if we could just give more drug in everybody, we'd get more out of it, it doesn't necessarily hold up with the available data. And obviously there's more to talk about here, but I wanted to point out to you that having other mechanisms and knowing when we should draw the line and move on to another therapy is a very important message. Also new and notable, and I know Dr. Cross will cover some of this as well, is the use of ustekinumab in ulcerative colitis. This drug, of course, has been available in Crohn's since 2016. Got approved for UC in the United States in October last year. This is, of course, an anti-P40 antibody, which hits both IL-12 and IL-23. The pivotal trial data are there for you to see, and it's the same dosing as we use for Crohn's, exactly the same, a weight-based IV loading dose and then injections every 8 weeks. And so this is now available to you, and we can talk more about that. Just a couple points about these other messages. One of the major themes in IBD that you should be knowing about now is this concept of treat to target or tight control. And what this basically means is identify a goal for your patient, something that's probably objective, and when you choose your initial therapy based on how sick they are as well as what their prognosis is, reassess the disease over time and adjust your therapy either to get to your target or to make a conscious decision with the patient that you're not going to move on to something else or you're going to continue to monitor them. And a very important concept in treat to target is after you get to the target, let's say you heal the bowel and the patient's doing great, recognize that chronic diseases tend to drift away from control. So a monitoring strategy is a critical component of treat to target. And if nothing else from my presentation today, I want you to start thinking about how will I monitor each of my patients to know how they're doing over time. And having that strategy for all your patients is really important. The traditional target is a combination of patient-reported outcomes, symptoms, with endoscopy. But I actually want to tell you that you can use all these other objective targets depending on your individual patient. Maybe it's CRP, maybe calprotectin is a better target. Cross-sectional imaging isn't used that often in the United States, but it's a reasonable thing to consider. And of course, using extraintestinal manifestations may be reasonable as well. So think about your individual patient, what would be the appropriate target for them? And in fact, we now have what we're considering a landmark study showing that treat to target in Crohn's disease achieved more mucosal healing as a primary endpoint of the trial than those who were treated based primarily on symptoms. So the algorithm you're seeing here was this treat to target study called CALM, in which patients got adalimumab at standard dosing and maintenance. If they hadn't hit their target or if they were having persistent symptoms, they went to weekly adalimumab. And this will tell you how long ago it was designed. If they didn't hit their target at that point, they added azathioprine. Okay? And the tight control arm were people who had adjustments made not just on symptoms, but also on calprotectin and CRP. And for the first time in one of our studies, the primary endpoint was mucosal healing. It wasn't symptoms. And you can see here that those who were in the tight control arm are more likely to achieve this. If you're a glass is half empty kind of person, or a realist, you also acknowledge that half the patients didn't get there. So there's a lot to do here, and it also tells you that we probably burn through most of our therapies if we hold people to too high of a standard. So treat to target is a general mindset. It doesn't mean we're going to get there for everybody, but it certainly doesn't mean you leave people with active disease and you ignore it. That's not the message. So we've in general been talking about if we can do this, we're going to change the natural history of IBD. So the term we're starting to use in IBD is what they use in rheumatology, disease modification. If you can control the disease in some objective way, you can change the natural history of the disease. Here's the follow-up from the CALM study. The people who had the mucosal healing, regardless of which arm they were in, by the way, were less likely to have surgery and hospitalization. So however you get there, if you're there, we know it changes your natural history, at least to the 2-year point. Moving on is just a couple slides on this very complicated topic of therapeutic drug monitoring. The AGA came out with some clinical guidelines. I've only highlighted a couple of them, but they endorse using serum concentrations of anti-TNFs for patients losing response to therapy. They did not endorse doing it in stable patients. And for thiopurines, they suggested routine TPMT before using thiopurine therapy. And I know that that's not as often being done because we've moved to methotrexate and other treatment options, but I think it's reasonable. I've added a bullet point here that if you have patients of Asian descent, and actually now even some patients of Spanish or Latino descent, we've learned that they can have a second polymorphism called NUDT15 that predicts early leukopenia. And that is actually available. You can order it through LabCorp and maybe other commercial labs. So you can consider ordering this before you treat them. In my own practice, even folks who have an Asian ancestry, I'm just checking a CBC at 1 week and making sure I'm being very careful as I move through this. But that's something new you might not have heard of before and you should know. The randomized prospective trials of therapeutic drug monitoring in IBD, there's 2 that have been negative, both published in Gastro. Taylor-Ricks and Taxit did not show that using levels and adjusting got you where you needed to go. And there's one that's now positive. This was in pediatrics. It's called the pilot study. It was based out of Israel. And this looked at kids on adalimumab. And actually, this is the first prospective study that says that even in stable patients, adjusting adalimumab levels and dosing can actually get more patients into remission and keep them there. So maybe we're finally moving to that, but we're not quite there yet. And the last slide on this topic is just optimizing treatment. That means, is the patient getting what you've written or what you've discussed in the office? A lot of times we know that doesn't happen. You should be thinking about combining therapies. We have strong evidence that for anti-TNFs, or at least infliximab, you should be using it in combination with something else. And when you start someone who has perianal Crohn's, there are now multiple randomized trials that say adding Cipro, at least during the loading phase of your biological therapy, improves response. I use therapeutic drug monitoring for patients losing response, but I also use it in patients who are high risk for loss of response. So those are your patients with a high inflammatory burden, or patients who are obese, men more than women, low albumin. There's lots of things that you can be thinking about in which measuring a drug level after loading may guide you in treatment. And the last point I have is on de-escalation. So this is something that every patient wants to know about. They ask before we even start a therapy, when will I stop it? And we know many patients go down on their drugs by themselves. In this cartoon on the left, I'm graphing out inflammatory burden in red. So a patient who gets treated with the drug, which is in green, can control their inflammation. And in general, the message has been that the induction therapy stays the same in maintenance. That's been the message for a long time in IBD. But what we've wanted to know is, can we actually reduce that when the inflammatory burden goes down? Can we withdraw the concomitant therapy? Can we reduce a dose or do something else when patients are doing stable? And if so, can we do that after a certain amount of time? How long would you wait? Maybe 6 months, maybe a year. How do you know when to do this? Well, there's emerging data and some discussion about this important topic. The first one is, of course, we've been doing this. We always take people off steroids. That's a concept of de-escalation. The second is that there's actually data now in an open label study that if you induce remission with a higher dose of 5-ASA, like 4.8 grams, you can drop it to 2.4 if their bowel is healed. Makes sense. And then with the concomitant immunomodulators and anti-TNFs, we do have some other data to say that this will work as well, where you could pull off the immunomodulator if the body has healed, if the bowel is in deep remission, and if you know that there's enough of the biological therapy on board so that when you pull off the concomitant therapy, it'll do most of the work. In the Tofacitinib data, and I told you we were going to come back to this, the clinical trial was designed for patients to drop to 5 milligrams after induction at 10, or to go to placebo after induction at 10, or to stay at 10. So for the first time, we have a clinical trial that was actually built where patients who were induced successfully actually had a scheduled randomized dose reduction. So here's de-escalation built right into TOFA. And the reason I'm highlighting it is because, of course, that's what the FDA wants us to do anyway. So what did we learn? Well, if people achieve remission with the 10 BID TOFA induction dose in the first 8 weeks, and you drop them to 5 milligrams BID, if they're in remission, 75% of them will do okay. 25% of them will relapse when you drop the dose. And it's a higher percentage of people who already failed biologics who are going to have that problem. Of those 25%, if you go back up to 10 milligrams, you can recapture half of them, only half. So you're going to take a chance there. So it's advised that you drop the dose, but think ahead. If you have a patient in which TOFA is your salvage therapy after they've failed 2 or 3 biologics, you really need to be thinking carefully about whether you're going to expose them to the risk of dropping their dose. And you're going to want to make sure that the bowel is healed and they're stable before you do so. So this is a very important sub-analysis from the TOFA clinical trials. So my last slide is really about how do you do de-escalation, sort of a new and notable concept. Make sure that you have a conversation with the patient about what their risk will be if they relapse. Some patients don't want to do this after you actually remind them that how sick they were when you started treatment. Confirm that they're in deep remission before you pull anything off. I recommend that this has been going on for at least a year. You want them to be stable for a long time before you start pulling drugs off. Confirm optimization of the drug you're going to leave behind. So the example is combo therapy with an infliximab and azathioprine. If you're pulling off the AZA, make sure that the infliximab is detectable and that the amount of drug there at trough is more than 10, so that when you pull off the AZA and it drops a little bit, you're not going to have a problem. Very importantly, to any de-escalation strategy, have a monitoring plan. After you pull off a drug or stop something, have a monitoring plan. And what's graphed out on the right there is our experience in 160 patients where our monitoring plan was doing calprotectin in both Crohn's and UC. And we were able to predict early relapse before a lot of patients had problems. So you need to have some plan so you know what you're going to do. You don't just send them out and say, let me know how you're feeling. And then lastly, you have to talk to your patient about the rescue. What's the rescue strategy? Are we going to go back to what was working before, or are we going to use this as an excuse to start you on a newer therapy, which we've done a lot of? So I'm going to stop there. I covered a lot of ground. I set the stage for some of our discussions and cases because Jenny shared those with me, and hopefully that's brought you up to speed on some of the things to keep in mind. Thank you very much. Now it is.
They are now.
It's on now.
Okay, hello? Okay, wonderful. Just a quick question. So if you have questions about this, why don't you write them down, and then we can, at the end, we'll have a question and answer session. I have one question for Dr. Rubin. So with de-escalation, do you feel that, do you introduce the topic to them, or do you only consider it if a patient asks?
No, I introduced the topic. I have a whole group of patients that I inherited from Steve Hanauer, who are older, who've been stable on a thiopurine and mesalamine, and every time they have their colonoscopy, they're in deep remission or even normalized. So remember that the lymphoma risk, although rare, does increase a bit in older men, especially after age 65 or so. So there's an example where I bring up the topic. Let's see if we can pull off your thiopurine, leave you on the mesalamine, we'll monitor you. And if you relapse, we're going to go to veto as an example. I'll tell you that despite the rationale there, and what you might think sounds like a rational plan, I've been burned too. Thiopurines work. So you pull them off on some people and they do relapse. So I do a calpro at 3 months, which is when you catch the early relapsers, but we've had people who are late relapsers too. So this is not something to do willy-nilly. And of course, we don't want patients to confuse being well because of therapy and thinking that it's in spite of their therapy. So you have to have a real conversation.
Okay, wonderful. Thank you so much. Okay, so for the next session, we're going to be revisiting a lot of the concepts that Dr. Rubin has set up in a case. So this first one is going to be a case, ulcerative colitis case, and what you'll find out is that a lot of the management here is not picture perfect, but I think that's part of the discussions that we're going to have as to what we could have done better, what was done really well, and how the patient's outcome resulted from these different decisions. So we're going to get started. So we're going to talk, this is a 19-year-old male. He has a history of ulcerative pancolitis, and he was diagnosed in 2014. You're seeing him now, it's 2019. So we're going to be reviewing some records between 2014 and 2019 regarding his management that may have led to how he's presenting in 2019. So he has no other significant past medical history, no past surgical history, has no family history, he's a non-smoker. So in 2012, 2013, he has some episodes of watery diarrhea that self-resolves. He doesn't seek care. He doesn't really look into any further management strategies then. In 2014, though, he starts having bloody diarrhea, and it's not resolving. So then he also has 20-pound weight loss during that time and some fatigue. So at this point, in March of 2014, he's admitted to the hospital. He has a colonoscopy then that shows he has moderate to severe pancolitis. The biopsies show mild chronic active colitis with crypt abscesses. He's also noted to be C. diff positive. He was treated with a course of metronidazole, and then he's on steroids from March to August of 2014, and he completes this course in August. Then in January of 2015, he started on a budesonide taper as well as mesalamine and mesalamine enemas for bloody stools and diarrhea. So I want to start off with the panel right now. How would you have managed this patient? This is going on now, his first presentation. So how would you have managed him differently in that first year of diagnosis? Dr. Cross?
So, David went over this really nicely. I think if you're trying to think about prognosis and you see, if you remember only one factor, the factor that this patient was hospitalized, particularly early after diagnosis, is putting him at a severe risk for colectomy. So certainly you're going to manage him with steroids in the hospital, and this is a person you could move right to biologic therapy on initially. Most people in UC are going to try to do a tapering course of steroids to high-dose 5-ASA. But then once you had any subsequent relapse at all, I think you should be moving to a biologic therapy. So if you have this patient in practice, you could, after the hospitalization and steroids, you could go right to biologic therapy. You don't need to wait and try the 5-ASAs. If you do, with the first sign of relapse, you have to move on quickly. This is a high-risk patient.
Right, exactly. So that's something that I wanted to keep us considering. And then he doesn't have any other therapies except for mesalamines. Then in February of 2015, he has a sigmoidoscopy at the time that shows severe left-sided colitis with pseudopolyps. And in the scope, they were unable to advance beyond 45 centimeters. Again, the biopsies show mild chronic active colitis, no evidence of granuloma. He's readmitted to the hospital, and he requires 2 units of blood transfusion. He's restarted on IV steroids. His hemoglobin improves from 8.3 to 10.6. And at that point, March 2015, his white count's 16, his hemoglobin's 10.6, platelets are 675, his albumin's 2.1. Again, he is C. diff positive. After discharge, he's on a prednisone taper. He started on vancomycin for 14 days, and he's on a mesalamine with mesalamine enemas with oral iron supplementation. So, for the panel, what clues in his clinical history hint to this disease course? Dr. Cross has mentioned that he's high risk. So what are those features that make this patient high risk, Dr. Rezapour? Are there thoughts that you have about his history?
Yeah, I think when we look at patients, I think risk stratifying them is really important. One of the things in his initial history, and one of the things we pay attention to, is the extent of disease. So he presented with pancolitis. He's also a young male, which I think are also predictors of disease severity. So I think that even on his initial presentation, he's also, I believe he said malnourished. His platelets are in the 600,000 range, so those are all markers of inflammation. And he's now presenting with C. difficile infection twice, which is likely going to be more difficult, and it's also could be masking some of his UC symptoms.
Yep, exactly. So this guy has definitely declared himself as a high-risk patient, and you find out later that this patient actually has been resisting therapy. That's partially why he has not advanced to biologic therapy earlier. How, Dr. Limketkai, how would you manage or how do you have these risk-benefit discussions with patients? They downplay their symptoms, they're concerned about chronic therapy, and Dr. Rubin as well. I'm sure we've all had these patients that come in, they don't want to advance to further therapy. How do you manage this, and what kind of discussions do you have with the patient?
Yes, I often talk to patients and tell them that I have two principal goals in their care. Number one is their short-term goals, and the other one is their longer-term goals. For the short-term goals, I actually try to focus on their quality of life and say, you know what, on one hand, what we want to do is get you feeling better. Trying to actually address your symptoms and getting you feeling as getting back to your normal quality of life. But even regardless of getting your symptoms under better control, I tell them that I still have another longer-term goal. And particularly for the younger patients, I kind of illustrate to them that statistically, they actually have several decades of life ahead of them. And that if they actually wanted to preserve their current quality of life, they would actually need to be more proactive about it and trying to address what the underlying drivers are for disease-related complications down the road. And that's where I bring them back to say, in that setting, the research have at least shown that the presence of persistent inflammation, even in the absence of symptoms, may actually drive longer-term disease-related complications and potentially changes in their disease or in the disease modification whereby it may become harder and harder to treat, and whereby they may actually encounter certain unfortunate complications such as colon cancer and repeated recurrent hospitalizations, or even fragility in their daily life, such as being able to feel stable and when will the next flare happen, or when will they need to be hospitalized again? And that's actually very disruptive also in a sense to their chronic quality of life.
Yeah, Dr. Rubin, do you have any thoughts on this?
In 2015, we published a paper in the Red Journal in which we described using treat to target as a way to negotiate with a patient who is resisting therapy or didn't want to be on it or wanted to try something that may not be as evidence-based, like diet. And what we said was that by embracing their wish but using objective measures over time, you can strengthen your relationship with them and work together. So the example here would be, I understand that you don't want to go on immune-based therapies, but we know that if we can't get your bowel healed, you're going to have another problem. And so we'll try this, but in 6 weeks we're going to repeat a calprotectin, for example, or something else objective. We actually showed as well in that same paper that I briefly mentioned, looking at Calpro as a way to measure de-escalation. We also found that you could use Calpro to predict steroid dependence. So if you want to know whether the patient that you're tiptoeing away from steroids over 3 or 4 months is actually going to fly, check a calprotectin after the first month of being on the steroids or on whatever other treatment you've started. If it's over 200, you're not going to be able to sustain them off steroids. They're going to bounce right back. So instead of waiting for them to call you that they feel worse when they drop below 20 milligrams, or that they're worse a week after they finally got off the prednisone because you went down by 2.5 milligrams every week, you can actually know what's going to happen. And so that's a pearl that might be helpful in your practice. The only other thing I wanted to bring up is that the Infectious Disease Society of America now embraces vancomycin as your first-line therapy for Clostridioides infection. And in IBD, where we haven't had as much study, we know that this certainly sets them up for resistant disease and relapses and surgery. We published a retrospective analysis of patients and found that those who were treated for 28 days with vancomycin had a reduced rate of recurrence. Recurrence is defined as test-positive symptomatic C. diff within 8 weeks of stopping antibiotics. So we now recommend in our own group 28 days of vanco when you start them for their first treatment of C. diff. And then, of course, if they have a second or third recurrence, you can think about doing intestinal microbiota transplantation. But that doesn't treat their colitis, unfortunately.
So will you consider intestinal microbiota transplantation after the first recurrence?
Well, we would consider it, but actually the FDA doesn't necessarily let us, so we usually are still doing it after the second recurrence.
So every time that you're requiring vancomycin, you'll do a 28-day course for them now?
Yeah, so the story behind this is that I was at a meeting with infectious disease folks about C. diff, and I was the only GI there. And I pushed them on this, and I said, well, what about our patients with IBD? What would you guys recommend? And with all due respect to them, they shrugged and said, treat longer. So I started doing this 5 years ago, maybe more. I started always treating for a month. And after a while, I started teasing my partners who do IBD that all my patients do better. And this was an ongoing joke. And then finally, I had a great medical student, Laura Glick, who's now an intern at Yale, who studied it. She pulled all the patients. We adjusted for all their risk factors, their exposures to therapies. And sure enough, we showed a significant reduction in recurrence and a numerical reduction in reinfection, which is having test-positive symptomatic C. diff after more than 8 weeks. So it wasn't statistical, but it was reduced. So we started doing this, and now our practice is doing it. We are doing a prospective trial to prove it.
Fantastic. That's great. Okay, so what I'd like next to do is I'll have Mona Rezapour come and talk about discussions of treatment escalation. She's going to talk about the risk profiles of the different medications we have available and how we can have those discussions with our patients.
Thank you. Jenny. Great. Thank you so much. I want to start by saying that it's such an honor to be on this panel with everyone. I'm a little bit nervous, as you can tell. And the other is that I want to thank Jenny for sort of highlighting the importance of patient education and counseling when it comes to the safety of the therapeutic medications we use. And I think I want to start by saying that, and if there's one thing you take away from this talk, it's really this slide, that, and I think Dr. Rubin also sort of highlighted this fact that it's truly active IBD and persistent inflammation that has far more consequences for our patients than any of our therapies, and these include malignant consequences, vascular, infectious, and neurologic. And I think Corey Siegel is sort of the, godfather of everything when it comes to talking about patient education, and I took this off of one of his papers where he talks about how patients conceptualize risk, and really he defines risk as the probability of a risk, the probability of an adverse effect occurring, and then the consequences of that. And how do patients really conceptualize it, and how do we really help them frame that conceptualization? And there are two factors that are used in this model. One is the dread factor, and the other is the unknown. And dread is really defined as, at its worst, as risks that are uncontrollable, those that are catastrophic, those that are inequitable. And unknowns are really those consequences or risks that are new, where the harm really develops later on in the course. And patients really, so for example, an example of that is mesalamine. So mesalamines are medications that we're all familiar with, and so are our patients. And actually, in a study, when they surveyed patients asking them to stratify medications based on their safety, really they were able to appropriately stratify mesalamines as one of the safest. And so mesalamines would, for example, be in the left lower quadrant. And on the other hand, biologics, for example, TNF and the risk of lymphoma in combination therapy would be in the right upper quadrant. And again, I think that it's our role as physicians and gastroenterologists to be able to really shift that mindset, and I think this model is really fluid. And we're really able to, by educating our patients about not just the risks, but how we frame them using absolute numbers instead of relative, and really allowing them to understand that, we monitor those outcomes, and there are ways, there are models we use for prevention that we can maybe shift their concept of risk from the right upper quadrant more to the left lower quadrant. And these are some of the tips that Corey Siegel recommended that I really liked. Again, using absolute numbers instead of relative, really avoiding small percentages, and instead, for example, the second one is the risk of lymphoma in combination therapy with thiopurines and anti-TNF. So instead of using a percentage like 0.6%, saying that the risk is 6 per 10,000. And he actually also recommended using pictures, which I'll come back to at the end, to even help further conceptualize that 6 per 10,000 person years. Using both gains and losses to diminish, framing that risk. So for example, the risk of PML in natalizumab is 1 in 1,000, but it's also important to mention that 999 patients out of those 1,000 actually don't develop PML. And then the last point really goes back to my first slide, that really discussing the risk of untreated disease that I think some of the panelists also mentioned is really important. I know this is a really busy slide, and I like to go through some of this with you guys, but this is what I meant in terms of educating our patients. And we have a lot of checklists for prevention and monitoring, and I think this is a really special place in terms of our role in the care of our patients. And some of these points that I will discuss really requires a multidisciplinary approach, I think. But the first is really doing laboratory work, including CBC and checking LFTs. These are both due to the side effects of some of our medications, including myelosuppression, hepatotoxicity, some renal insufficiency. And then it's also, some of these testing is used as infectious risk assessment. So for example, checking hepatitis B serologies. I think we all know the risk of reactivation of these by now, but just to highlight, hepatitis B surface antigen individuals really should be on antiviral therapy while they're on biologics, especially anti-TNF. Those with surface antigen negative, surface antibody positive, I think is a little area of uncertainty, but I think it's a discussion between the patient and the physician. And really, if the decision is to not start them on antiviral therapy, that they require frequent monitoring. Then tuberculosis, TB testing with quantiferon gold, again with the risk of reactivation. And with that, it's recommended that in areas where TB is not endemic, to continue monitoring and checking TB testing with quantiferon gold every 2 to 3 years, and in endemic areas every year. Although I will say that in my training, we checked yearly. And then EBV testing, there's a little typo, but with EBV testing, I think again in young males who are on thiopurine therapy, who are initially EBV negative, if they develop acute EBV infection, they're at risk of EBV-associated lymphomas. And so we need to check a one-time EBV antibodies. This slide is so small I can barely see. Cancer prevention is obviously very important. Pap smears with cervical, due to increased risk of cervical cancer, most of our, or all of our female patients should get annual pap smears regardless of negative testing in the past. The other is annual skin check exams. I think that we are all at this point aware of both increased melanoma risk with anti-TNF therapy and the risk of non-melanoma skin cancers with some of our other therapies, including thiopurines, tofacitinib. I think some of the trials in vedolizumab also showed a few cases of both melanoma and non-melanoma, but the melanoma cases had been on anti-TNF previously, and the non-melanoma cases were either on thiopurines or had previously been on them. And then I think, again, the next point is the one in terms of vaccination that really requires a multidisciplinary approach with our primary care colleagues. And so I think vaccination, and I think there's a lot of room for improvement in this area. These are some of the ones that I think we should always keep in mind. Flu vaccine annually, pneumococcal, both PCV 13 and 23. I think Dr. Rubin mentioned HSV testing with now the inactivated Shingrix vaccine. Now, I think it's important to keep in mind that HSV vaccines are recommended in patients greater than 50 years of age, and Shingrix was not studied in immune-compromised patients, so it's not actually in the immunization guidelines. But again, as Dr. Rubin mentioned, all of our patients, especially with the risk of herpes and tofacitinib trials, should get the Shingrix vaccine prior to starting that therapy. Now, insurance coverage may be a different issue. And then I think, again, we're all sort of aware that live vaccines are really contraindicated in immune-suppressed individuals. The CDC advises, I just put that in the corner as a reminder to all of us that really we can give live vaccines to patients who are on prednisone less than 20 milligrams, azathioprine and 6-MP if the doses are less than the ones on the monitor. And then also, in terms of vedolizumab, I think it's important to discuss the risk and benefits of vaccination, live vaccination in these patients. So if the benefit outweighs the risk, that it's okay to receive those vaccines. And then some other preventative measures is bone mineral density testing, depression screening, smoking cessation, and annual eye exam. And I think the Crohn's and colitis and also cornerstones have great checklists for all of us to use. Again, it sometimes can be difficult in our visits to cover all of these healthcare maintenance, but these are great tools for all of us to utilize. This is, again, just to more go back to that initial slide of putting a framework for the patients to conceptualize risk and really allowing them to understand that when you're talking about therapies and immune suppression, that you're really weighing the risks and benefits of immune suppression versus the risk of ongoing active disease and the complications of ongoing IBD, which include infection, complications, cancer, and others. Now I'll discuss each of the main biologic therapies that we have and some of the adverse effects associated with them. Starting with anti-TNF, I think I've highlighted some of the more important ones. Of course, skin and infusion-related reactions are ones, and these are actually sometimes some of the reasons why our patients stop therapies. The others are immunogenicity, especially in the first year, can be very high. This is, again, why we often recommend starting combination therapy, and goes back to sort of the SONIC trial showing that combination therapy had better outcomes as compared to monotherapy. And then some of the neurologic consequences and non-Hodgkin's non-Hodgkin's lymphoma or lymphoma in general, including others like B-cell lymphoma. Again, the frequency of them is about 6 per 10,000 person-years in combination therapy with anti-TNF and thiopurines. And I'll discuss this a little bit later at the end. In terms of vedolizumab, I think I've highlighted the important factors at the bottom, that there's really no case of progressive multifocal leukoencephalopathy with PML. The malignancy rates are very low, and most of the ones in the initial trials were GI-related malignancies. There's very low immunogenicity, about 3%. It can be as high as 4%, but if they're using combination therapy, you can decrease that immunogenicity further down. And then, there's low infusion-related reactions as well. This was in the ACG 2019 annual conference, the EVOLVE study, which looked at both Crohn's and ulcerative colitis biologic naive individuals and looked at the safety of vedolizumab versus anti-TNF, and these are this graph includes both Crohn's disease and ulcerative colitis. And as you can see here, both in terms of severe adverse events and serious infections, the rates were much lower in vedolizumab as compared to anti-TNFs. I think I already covered this. In terms of ustekinumab, in the maintenance trial up to 44 weeks, nasopharyngitis and injection site erythema were, there was a increased risk associated with those. But I think overall, on the right-hand side, you can see that there's no FDA black box warning. There were no deaths associated with ustekinumab, and also there were no differences in severe adverse outcomes between the ustekinumab arm and the placebo arm. And again, the immunogenicity with ustekinumab is about 2.3%. Tofacitinib, again, the elevated cholesterol, both total cholesterol, LDL and HDL, which was discussed previously. These do increase in the first 4 weeks, and then over the next 3 months of therapy do stabilize. They're seen more commonly in the higher doses, was already discussed. And really, the cardiovascular impact is unknown. And then herpes zoster, and I think, again, these have been reiterated a couple of times, but what's important to also mention about herpes zoster is that it really just affects 1 to 2 dermatomes, and most patients who got herpes zoster didn't have to stop therapy. And then I think it's important to just, again, this was, Dr. Rubin covered this, but this was the study Dr. Sanborn did where he looked at the phase 2 and phase 3 induction and maintenance trials, and also the open label long-term extension. This was just, I think, a study just to present the data to all of us. And what he showed is that the first column is the induction cohort, and really there were only 1 case of DVT and 1 case of PE in the placebo. So no patient on tofacitinib developed DVTs or PEs. Same in the maintenance trials. There were 1 case of DVT and PE in the control arm, none in the tofa arm. And then the overall, the third column you're looking at is the overall, which really includes the long-term extension. That's where there were 5 cases, 1 DVT and 4 PEs, and these were all in the 10 milligram BID doses. Now, all of these patients, I think, in the paper, he goes over the history of all these patients, and all 5 of them had thromboembolic risk. These included either previous history of thromboembolism, thromboembolic stroke. There was a young girl on oral contraceptives. There was someone on a long flight, and a patient with metastatic cholangiocarcinoma. And so I think it's just important to keep those, again, in mind when we're thinking about these therapies in our patients. I think pregnancy and IBD is a really important topic to discuss, and I think a lot of us, when we see pregnant patients in our offices, are automatically uncomfortable. And I think that's partly because they're a very delicate population. I will refer you to AGA, which has a new pregnancy and IBD pathway that's extremely comprehensive. So I just wanted to mention a couple of points. One is that most of our medications are safe during pregnancy. The exceptions are methotrexate, which really should be, it's contraindicated, should be stopped about 3 months before conception. Cyclosporin, but I think a lot of us really shouldn't, it's not used in maintenance therapy, and a lot of us don't use cyclosporin. It's mainly, at this point, used at tertiary centers for induction in really sick patients who have otherwise failed other therapies. And then last is tofacitinib, which I think we just have limited data on, and I believe the IBD pathway in AGA recommended that it really not be used in the first trimester. I think the other important point to mention is that although thiopurines are safe to use in pregnancy, if we're using them in combination, we should think about stopping it just due to the increased risk of infection. The other is that we really shouldn't be starting these medications during pregnancy because of the increased risk of pancreatitis. I think I discussed this. I just want to show this chart that, again, Corey Siegel put together. I think we've all seen this. That really puts into perspective to patients how low that risk of 6 per 10,000 is. And then I think again, this was covered in details, just a few points. So TNFs, again, based on several studies, the CALM Treat to Target, REACT study, SONIC, should be used in combination, and then we can start de-escalating after 1 year. The studies on de-escalation showed the rates of relapse are low, up to 2 years. The exceptions, again, are trying to risk stratify patients, and those with severe disease or fistulizing disease, we should likely think about not de-escalating. Ustekinumab and vedolizumab are safe to use in monotherapy, except those who have prior immunogenicity. And then in young males, again, using maybe methotrexate instead of thiopurines in combination therapy to the risk of hepatosplenic T-cell lymphoma. And then I just have to end on this. I hope I'm not committing blasphemy by changing Dr. Regueiro's safety pyramid. But this is a paper by Ben Click and Dr. Regueiro. It's a great comprehensive practical guide to safety of our therapies, where they suggested this pyramid with steroids being at the bottom. It didn't even deserve a place in the pyramid. It's like below the ground, and then going up to vedolizumab at the very top. And I just changed, and I put tofa above thiopurines, and I think I wanted to just look at it more globally in terms of responsive therapy, outcomes, and adverse effects. So I think, and again, we use thiopurines a little bit less often these days, so I kind of put that a little bit below tofa. And thank you again.
Thank you so much for that comprehensive review of the risks of all our therapies. So let's go back to the case. So this patient, now it's March 2015, had a quantiferin TB test that's positive. His chest x-ray is clear, and he started on isoniazid. So we're thinking this patient is probably on his way to requiring a biologic therapy. What do you guys do in your practice with patients like this? How long do they end up being on anti-TB therapy prior to initiating a biologic?
I think if it's an outpatient, 2 to 4 weeks is sufficient of INH or whatever they're using. I think it's still INH. If it's a sick inpatient and they don't have any signs of active pulmonary TB and you're not using cyclosporin, although that would still be an issue with the intense immune suppression, I would just give the drug while you're concurrently treating with INH.
What was his risk for TB?
I don't know, but he was positive. Like he was positive. So he travels. He's a kid. I mean, he's in his 20s. He may have gone somewhere.
So this is latent TB. He doesn't have any active TB on evaluation. We would start the isoniazid, but I would start his treatment for his colitis fairly quickly after that. You could reconsider whether you're going to use an anti-TNF. You do need to address this issue with the other biologics, but the primary reason is not because vedolizumab or ustekinumab increased the risk of activation of TB. It's because in the clinical trials, all the patients were screened for TB, and therefore in the label, it's mentioned, and therefore payers require it. But the reality is that I wouldn't worry as much. So if you're nervous about it or there's some confusion, you should still end up treating it if you can, but then you can use a different therapy if you want.
Would that adjust your choice if this was a person that had real risk factors and this is a patient that also has pretty high risk features for in his ulcerative colitis?
Well, I'm a bit biased. He has a low albumin already and has had a number of features that make me anxious about his condition, and I might have actually tried to start with an oral therapy, a small molecule, to avoid leakage of monoclonal antibodies. That's my bias. The evidence would suggest that the strongest therapy for severe colitis might be infliximab, and I don't think I would hold back on that if I'm putting him on isoniazid at the same time. It doesn't change anything.
Okay, so that's what was started. He was started on infliximab at 5 milligrams per kilogram monotherapy. Dr. Rubin, you did mention earlier that there is no data to suggest higher doses for initiation.
Well,
now, someone with a low albumin, is there a concern that maybe we could do something differently?
Well, we can talk about what's the risk that this person's going to be a rapid clearer. I mean, the reason people develop monoclonal antibodies are pseudo-episodic therapy, meaning they get a dose and then they bottom out the level, so the next dose is like an episodic exposure. The other reason is now this new data from the UK that suggests that a certain HLA type predicts immunogenicity, so some people are more likely to be antibody formers. We haven't started doing that in clinical practice quite yet, but he might be at risk there. And you're worried that that could happen. So my question isn't about the data to support accelerated dosing as much as the data to support using combination therapy. And I'll just remind you as well that combination therapy in the short term includes steroids. So if he's on prednisone with infliximab, that protects him from antibodies in the first dose or two. But ultimately, I probably would want him to be on either oral methotrexate or thiopurine combo therapy. And then I would consider going to a higher dose right away if he's not responding at least once.
Mm-hmm. All right.
So Jenny, we were using, at Maryland, we were using high dose in all of our sick inpatients, and we anecdotally felt like that was making a positive impact, and we actually found that our pharmacists were tracking our use of inpatient infliximab.
Of course they were.
And they came to us as partners to say, let's look at your outcomes and let's track it. And so we looked at 5 versus 10, and then we looked at the patients that I think David mentioned that might get another dose within a few days, so 10 plus. So the message here is that 10 plus did very bad. They did poorly. Because they were the sick patients that you were giving another dose. But 5 versus 10 in our 50-patient study didn't make any difference at all. So we went back to just giving everyone single dose. And if they've had what looks like a response but not a response that's going to get them out of the hospital, then we might give them another dose. But we just start everyone on 5 now.
Interesting.
Oh, that's very interesting. Okay. And then I know at University of Chicago, you have the ability to check levels pretty quickly, right? Do you do that?
No, it's a send out. We still have to wait.
Oh, it is still a send out. Okay.
Yeah.
Mm-hmm. And so that's interesting. So you are starting 5 on everyone then, Dr. Cross, at University of Maryland.
Now
Okay.
I do after we looked at our data.
Yeah, because I think we are using higher doses here at UCLA.
The message is regardless that you want to make sure you know whether they're responding. And so in an inpatient, most of us will use CRP if they make CRP as a way to follow that and to watch it come down. He doesn't make CRP, it looks like.
Yeah,
Or maybe
well,
that's
he
after
did
he's
initially.
doing great. Okay.
Yeah, so he did.
So you can use that, and you just don't want to sit on a therapy that's not doing what it's supposed to do. You know, you've got other options, and I would argue that this young man has high risks for needing surgery, and that should be in your conversation as well.
Yep, exactly. So he feels very well on infliximab. He was placed on monotherapy. He's had 1 to 2 bowel movements a day. His stools are formed. He has no blood in his stools. He denies any nocturnal bowel movements. He's off of prednisone. So it's November now. His hemoglobin's 10. His MCV is 76. CRP has decreased to 0.4, and his albumin is at 4. So he's actually done quite well. So now he doesn't have any follow-up, clear follow-up until 2017. All of a sudden, he has increased stool frequency, has blood in his stools. So my question to Dr. Limketkai is, before the flare in 2017, would you have performed any other evaluations or treatments on this patient and when he was in clinical remission?
Yeah, certainly. So similar to what Dr. Rubin had mentioned during his talk, close monitoring is actually important. And the other thing we also consider is that, the absence of symptoms does not necessarily mean the absence of inflammation. And the third part is that, despite him actually having felt well while on infliximab monotherapy, we also don't know whether he was actually adequately dosed and whether he had then developed antibodies in the interim. So there's several factors that actually then, warrants closer monitoring during the interval. And, and it is unfortunately quite the temptation for patients to say, oh, I'm feeling well, so therefore I don't really need my follow-up as much. But this also illustrates how, follow-up with the patient, not just from the symptom standpoint, but also from other markers are important for their care.
So how would you monitor Berkeley?
Yeah, so on one hand, you could potentially either do interval calprotectins or stool tests for assessment of intestinal inflammation or the colonoscopy. So I don't see here anything of note whether actually a colonoscopy or endoscopic performance was performed after initiation of therapy. And this also goes back to, similar to what I mentioned about the IOIBD, having the STRIDE consensus statement about treatment to target and then monitoring after the initiation of biologic therapy. And the thought is that potentially doing something of that within at least roughly 6 months after initiation of therapy.
Exactly. I think what this patient was missing was a colonoscopy to prove mucosal healing, and there wasn't really a clear strategy at this point to be able to say that he really achieved endoscopic and he was in clinical remission, but endoscopic remission. So I think that's very important. So now he's here with the flare-like symptoms. You check a calprotectin, and it's at 1568. His C. diff test is negative, but he has 10 bowel movements a day. He has blood in his stools with abdominal pain. A steroid taper is initiated. So questions to the panel. So we talked a little bit about what information would have been helpful to determine management strategy. So depending on the results, what treatments would you consider next? So what should we do right now to understand what's going on with this guy?
So David and I were talking a bit while the case was going on, and he mentioned asking the patient if he's actually been taking his medicine, if he's been actually skipping doses, so understanding his adherence. So assuming he's a working male, a single working male is the highest risk for non-adherence that we have in our patient population. But I think the most important thing to determine what you're going to do next is drug levels, knowing if he has antibodies. So you know he responded. In Crohn's, it'd be much simpler. It'd be easier to go to a second anti-TNF with concurrent immune suppression. And UC, I think our sub-Q agents are inferior to infliximab. So I think no matter what, you're probably going to Veto or ustekinumab. But I still think having that information about what the drug level is and whether there's antibodies is very important.
Great, so that's what happened. So he had antibodies performed. There was no detectable serum level, and he did have significant antibodies noted, a titer of 60. So, okay, hindsight's 2020. Do you think there was a role for proactive monitoring this patient? Should he have had monitoring done beforehand? Should we have seen where his levels were when he was feeling well? Dr. Rezapour, what do you think? Do you employ proactive monitoring in your practice?
I do, and I think a lot of that, again, going outside of the guidelines, which didn't recommend proactive monitoring, a lot of that comes down to where you trained and what the physicians in your practice do. So where I trained with Maria Abreu, we did proactive monitoring. So with anti-TNFs, we checked a level before the first maintenance dose.
Yeah. And then I think Dr. Rubin had talked about how combination therapy is important for these potential rapid clears. So if he were on combination therapy, do you think this would have been a different scenario?
Well, I'm not going to pull a Bill Sanborn here. And some in the room know what that means. Just in the sense that if you look at available evidence, we have a prospective randomized trial that says that combination therapy in moderate to severe UC of infliximab with AZA is better than either alone. And in post hoc analyses in the similar study design in Crohn's, we learned that the drug level was more important than being on combo, but that combo protected people from developing antibodies, presumably because they weren't dropping their drug level too low and having that type of problem. So as much as I completely agree that I would check a post-loading level, I don't have any issues with that, and I would do it. He's high risk. I think that having him on combo therapy in a setting like this is supported and should be done at least initially until you get him out into the woods. I also, of course, support what Ray said regarding having a conversation with him about why he's on maintenance therapy after he feels well and is very high risk for relapse.
Right, exactly. So which combination therapy do you choose? There's a lot of concerns with the young male population about 6-MP infliximab combination. Does that influence your practice in terms of what you would choose? So Dr. Cross, what would you do?
So I don't use a lot of combination therapy. So I use combination therapy. I do offer it to patients, as David said, because I think the best evidence we have suggests that combination therapy is superior. I do offer it, but I usually do monotherapy with proactive monitoring. The scenarios where I do give combo therapy is patients with perianal Crohn's. I don't really give them the option so much in that scenario, and those that have formed antibodies previously. So if I'm giving it just to prevent immunogenicity in a young male or even in a female, I'll do low-dose methotrexate. It's easier to get people on. It's better tolerated. If I'm using it to do dual mechanism of action, I would give a thiopurine even in a young male.
So just, Ray, can you teach us all what level do you look for when you do a post-loading level or an early level, and then how would you adjust if it's not there?
So I have a nice table in my talk that I'm going to show,
Oh, okay. Well, then we can wait.
for infliximab, I
Sorry.
usually do a week 6 level because they're coming into the infusion center, so it's very convenient for us to send it off, and I shoot for 15 or above, and if they're below 15, then I'll just adjust their maintenance interval. So I'll bring them back at 4 weeks later or 6 weeks later, and I'll check the level again to see if I've gotten it right, with a goal being between 5 and 10. That doesn't mean if it's 4.5 that I'm going to raise the dose necessarily, but ideally you want them to be 5 to 10 if you're in the United States, 3 to 7 if you're in Europe.
Okay. So let's say if you were to start the patient on combination therapy, do you plan on de-escalating the immunomodulator later? So we talked about that a little bit. So within a year, after a year, you'll consider de-escalation in these patients?
Yeah, I think David mentioned this, but typically you're gonna check for mucosal healing, make sure that they're in a deep remission, and we can talk about how you would do this, but generally if I only was using this for immunogenicity prevention, and I had very good levels, and he has now learned his lesson that he needs to be monitored and stay on meds, and I would consider withdrawal between a year and 2 years, something like that.
Okay, well, this is a very nice setup for Dr. Cross, so he's going to give his presentation on therapeutic drug monitoring, his approach. It would be nice if Tricia James is here, if we can have the clock set, just to make sure we're on time.
Okay, so first, before I start, I just want to thank Jenny for inviting me. It's a great honor to be here and to participate. So this is, when I was doing this talk, I tried to think of some different scenarios that occur in practice so I could show you how I think about therapeutic drug monitoring. David already mentioned the guidelines, the AGA guidelines on proactive versus reactive monitoring. So if you take only one thing away from this short lecture, it's that when a patient is doing poorly, whether they're having symptoms, their biomarkers are increasing, or they have persistent endoscopic activity, a patient on a biologic or thiopurine, you should check a drug level. So if that's all you take from my talk, then we've won. Proactive is very controversial. This to me is the no-brainer, I think. That's why I put the scarecrow on here. So this is a 35-year-old white female with inflammatory ileocolonic Crohn's disease. Started on adalimumab due to non-bloody diarrhea and right-sided abdominal pain after ileocolonoscopy confirmed moderate endoscopically active disease of the ileum, ascending colon, and transverse colon. She was also started on budesonide 9 milligrams daily with standard induction dosing of adalimumab. Experiences resolution of symptoms within a month. Budesonide successfully tapered off after 2 months. 6 months later, she develops recurrent diarrhea and abdominal pain. So this is an example of when you would do reactive therapeutic drug monitoring. And it's primarily based on one moderately sized study from the Mayo Clinic where they looked at their experience with adjustment of infliximab based on drug levels. And what they found is that if patients had antibodies to infliximab, it was a much more successful strategy to switch to another anti-TNF. In this case, it was almost always adalimumab, than trying to overcome the antibodies with dose escalation. Conversely, if they had low drug levels without antibodies, raising the dose was effective almost 90% of the time. It was less effective to switch drugs. So this is another case, what I consider reactive therapeutic drug monitoring. So 35-year-old white female, again, with inflammatory ileocolonic Crohn's, started on adalimumab, same scenario, started on budesonide as well as with azathioprine, 125 milligrams daily, which is 2.5 milligrams per kilogram per day in this patient. Again, does well, resolution of symptoms, budesonide is tapered off. 6 months later now, she feels great, has a normal CRP, and it was increased at baseline, which is important, so that's a marker we can track, and we've confirmed mucosal healing. And she actually inquires about stopping azathioprine. So what do you do in this situation? So this was a study of over 200 patients with Crohn's that were on maintenance infliximab. The majority were on combination therapy. And what they looked at here is in patients in which they withdrew the immune suppressant, what happened based on the drug levels. So if the drug levels at the time of withdrawal of immune suppressant were 5 or higher, the patients did very, very well. If they were less than 5 but detectable, you could see about a 15% loss of response after a year. If they had no drug in their system and the thiopurine was pulled off, they all did very poorly. So what I do in clinical practice is I verify that they're in deep remission, as we did here. I check a trough biologic level as well as a thiopurine level, if appropriate, before I withdraw the drug. So if the thiopurine level is less than 125, it's probably not preventing significant immunogenicity, nor is it raising drug levels, so you can probably withdraw the drug without any worry. If the infliximab level is just around 5, I have a lot of concern about pulling the drug off. I still may pull the drug off, but then 2 months later, I'm going to recheck biomarkers and recheck a drug level to make sure that the level hasn't dropped into a range in which I think they could relapse or develop immunogenicity. So now the next few slides are going to be on proactive TDM. So we're going to change this to a 45-year-old Caucasian man with pancolonic ulcerative colitis, currently with more than 10 bloody stools a day, nocturnal awakenings to defecate, severe urgency, crampy abdominal pain with defecation. He's experienced weight loss and anemia with iron deficiency and an elevated CRP. Sigmoidoscopy is done and shows severe endoscopically active colitis with deep ulcerations. So in this case, he was started on infliximab, 10 milligrams per kilogram at week 0, 2, and 6. So what's the data on proactive drug monitoring? So really, I think the first study that really looked at this was Adam Chafitz's group at Beth Israel. And what Adam would do, he would proactively check drug levels and adjust according to the presence of antibodies and whether they were below 5 or above 10. In patients that were above 10, he would de-escalate their dosing, either by lowering the dose or lengthening the intervals. If they were less than 5 without antibodies, he would give them an extra vial of infliximab and recheck. If they were below 5 with high antibodies, he would switch drugs. And if they were in the range of 5 to 10, he maintained. His partner, who I will not mention his name, did not agree with this strategy, and basically they compared their outcomes over the course of several years. And that you can see that the proactive strategy in blue is much more effective than the reactive monitoring that was done in red. So this is really the first study that really highlighted the value of proactive drug monitoring. This is data from our practice at University of Maryland. So we looked at 235 patients over 2 years. We had 3 strategies. The control group in red was a group that decisions were made based on clinical symptoms alone without the use of any drug levels. So this was the old days. You would just bring them in at 6 weeks instead of 8 weeks or double the dose empirically. The reactive group is in yellow, had only TDM done when they had symptoms or some other reason to trigger a look. And the proactive group is in black, and they had pre-specified time points, which I'll go over, at which we checked levels. And this was both infliximab and adalimumab using the LabCorp assay. So that was, let me go back, that was persistence, which was much better in the proactive group. Reactive and control were not significantly different. But I think this is really exciting. It's going to be hard to see. But in the proactive arm, you can see straight down the middle, we saw much less healthcare utilization. So there was less IBD-related hospitalizations, shorter length of stay, decreased surgeries, decreased procedures, ER visits, office visits, et cetera. We also looked at dose. So what we did is for infliximab, we adjusted everyone to milligram per kilogram per month. And for adalimumab, we adjusted it for milligrams per 2 weeks. And in the proactive group, we did use more drug than the control group. It amounted to 1 to 2 more vials of infliximab every 8 weeks. And there was no significant difference with the proactive with adalimumab compared to the other groups. So we could achieve these results generally without using doses more than the other groups. So I think this is pretty compelling, and we've submitted this for publication. Now, these are the randomized controlled trials, so I'll give you a different spin on these trials. So for Taxit, these were patients that were on stable infliximab for maintenance therapy. It does not mean that they were in remission. Okay, so all patients at initiation had a drug level drawn, and they were all optimized to get between a level of 3 to 7. By the way, they also could be de-escalated if they were super therapeutic. So one of the key take-home messages here is that with one look in patients who are on stable therapy, you could increase them from 65% to almost 90% if you had Crohn's, and you see it didn't really pan out. In Crohn's, you could also see a significant reduction in CRP. Then the primary endpoint was clinical and biologic remission rates compared to the proactive versus the standard care group, and you saw no difference. But if you, again, dig into the weeds here a little bit, you can see some signs that proactive is effective. So fewer patients needed rescue therapy in the proactive arm compared to the control arm. Fewer patients had undetectable trough concentrations. More patients stayed in the target range. and the doses were still similar between the groups because some patients were undergoing dose de-escalation as well. So I think there are some positive points about Taxit, not a negative study in my opinion. This trial is a little harder to figure out. So there were 3 groups. So group 1 had adjustments in infliximab dosing by 2.5 milligrams per kilogram up to 2 times based on symptoms plus biomarkers or having a drug level less than 3. The second group had 1 adjustment by 5 milligrams per kilogram based on the same criteria. And the third group adjusted only based on symptoms and biomarkers. And David already showed this. You can see no matter what outcome you look at, patients, it didn't seem to matter what strategy you used. They did have, I think, fairly high rates of endoscopic improvement, which are encouraging, and this was a fairly small study. David also showed the pediatric trial, which is published online ahead of print, multi-center, non-blinded trial of adalimumab maintenance therapy with proactive monitoring after week 4 and onwards, and using a threshold of 5, which is a little lower than my preferred target, showing that patients in the proactive arm had steroid-free clinical remission at much higher rates than the reactive testing group, almost 2-fold higher. So the first randomized controlled trial to show the benefit of proactive drug monitoring. So this is another example. I mentioned that I don't use a lot of combination therapy, so some, like Marla Dubinsky, have argued that proactive is a way to avoid concurrent thiopurine or methotrexate. So this is, again, coming back to the 35-year-old woman with right-sided iliac inflammatory Crohn's disease. She has confirmed endoscopically active disease. We recommend starting adalimumab and azathioprine at standard induction and weight-based dosing, respectively. But she expresses some concerns about the risk of infection related to combination therapy due to her job as an RN in a nursing home, as well as a recent diagnosis of lymphoma in her mother. So David mentioned this. I'll show you the data. This is from Sonic. So for those of you that don't remember, Sonic randomized patients to azathioprine, infliximab, or combo therapy, and combo therapy was superior to infliximab monotherapy, which is superior to azathioprine monotherapy. But when they did subgroup analysis looking at drug levels and focus on quartile 3, which is going to be a level of 2.36 to 5, and quartile 4, you can see that if you can just get a reasonable infliximab level, having concurrent azathioprine here in red is not more effective than just infliximab monotherapy. So this teases out that it really is the drug level, not the concurrent immune suppression. What about de-escalation? So that 45-year-old with pancolonic UC was started on infliximab high dose. Week 6 level was good at 18. He has resolution of symptoms. Next infusion scheduled at week 14. The week 14 trough is excellent, also at 7.5. Everything gets better. Anemia resolves, CRP normalizes. We do a 6-month sigmoidoscopy, and he has mucosal healing from the rectum to splenic flexure. And 15 months after presentation, we do another trough, and the infliximab level is 14. So this is an opportunity where you can now lower the dose to 7.5 and monitor the level again after a few infusions to decrease cost. Having said that, there have been no studies linking higher drug levels with adverse events. So there's nothing wrong with leaving him right where he is, but if you're cost conscious, you can de-escalate. So this is my final slide. So this is how I do it in clinical practice. So infliximab at week 6, I want my level to be 15 and above, and before my first maintenance dose, and then annually I check them again, and I want them to be 5 to 10. In vedolizumab, I'm going to skip. I also do a week 6 level. There's some controversy over where the week 6 level needs to be. I shoot for the upper 30s, and I check again before the first maintenance dose, and annually shooting for a level of 14 or above. With adalimumab and certolizumab, I check around week 8. Adalimumab levels, generally we target 8 to 12. In certolizumab, we're looking at 20 or above. And then I check them annually, shooting for the same levels. Now, ustekinumab, I haven't figured it out. I'm not sure where it's supposed to be. I currently only do reactive testing with ustekinumab, and the level there depends on what's happening with the patient. So at least it has to be detectable. We know that for sure. And there's one study linking higher levels, 4.5 or above, with better outcomes in a Canadian study. So I think there's going to be more to come on drug levels with ustekinumab. Okay. Thank you
Wonderful,
very
Dr.
much.
Cross. Thank you. I have one question for
Yep.
you. So there's been some studies that suggested if the infliximab level is actually lower than that target of 5, but the patient has been in a deep remission for years, that they actually may be one of those candidates who do well without therapy. How does that play into your decision on whether to dose escalate someone who's actually on the lower side when they've been in a very nice deep remission for years?
So if a patient has an infliximab level of 3.2 and they feel well, their labs look good and their scope looks good, I don't change them. I think if you're above a threshold of 3, you're not really going to develop immunogenicity. If that patient was 1.2 and doing well, it brings up one of two thoughts. One is, are they going to develop loss of response over time, which happens in 15 to 20% of patients per year. In that case, I may dose escalate them just to prevent immunogenicity. The other thought is, if they've been on the drug for a long time, is the drug doing anything for them anymore? Is it, because it's at a low level therapeutic range, is it even helping them? But when it gets really low, I do dose escalate even if they're feeling well to prevent loss of response. And I think that's the main benefit of proactive monitoring, is to prevent that loss of response due to immunogenicity over time.
Wonderful. Thank you.
Yep.
All right, wonderful. We're going to get going. So the other thing that was going on with this patient is he's had some iron deficiency anemia. Dr. Limketkai, how do you deal with iron deficiency anemia in patients with active IBD? Is this an important point to treat?
It certainly is. I mean, anemia can also cause a lot of symptoms and iron deficiency as well. In a setting of active IBD, the thing I often tell patients is that, you think of it as a gasoline tank. Either on one hand, you actually have a leak in your tank, and the other one is you don't actually have enough because you're consuming too much of it. And the leak is basically when they're actually having a lot of bleeding, and in this case, this patient's an ulcerative colitis patient. They could have a lot of iron losses through that, and the other way they could actually have iron losses is through poor absorption, and the third mechanism would be the presence of inflammation itself. And then fourth could be also, alterations in how much iron they're taking in by mouth. So I first try to understand what the mechanisms or drivers of the iron deficiency are, and then secondly, is to say that we're going to actually approach this from a multi-pronged strategy. Number one is to try to treat the active inflammation, which would be also a cause for anemia. But secondly is, what can we do to replete? The unfortunate thing is that, oral, like ferrous sulfate, oftentimes can cause GI discomfort and, changes the color of the stools. And it's also not as efficacious at raising the iron levels. And so in those individuals, we'd actually give them IV iron infusions. Again, not necessarily in isolation, but also concomitantly with trying to address their inflammation.
Okay, wonderful. Thank you. So this patient ends up getting adalimumab as his next therapy. Sorry, we missed this one slide. So he's initiated on adalimumab. His iron levels have been low at 17. His adalimumab had helped. He had no levels checked, but from December to about February, this was helping him. But then from February to June of 2018, he's had various prednisone tapers with flaring, with each taper. And he cannot get below 30 milligrams of prednisone now. So he has no abdominal pain, no joint pain, no blood in stools, soft bowel movements twice a day, no diarrhea. His hemoglobin then after, this is April, is at 13.4. His CRP is at 21.7. His TPMT is normal at 18. So then in June, he has the PCR that's positive again. So first Berkeley, Dr. Limketkai, he talked about how to deal with the iron deficiency. So, how would you have treated his iron deficiency, Dr. Limketkai?
Just for clarification, you're asking how would we treat his iron deficiency?
Yeah, so how would you have treated his?
Yeah, no, certainly. So, in the absence of any active, bloodstream infections, I would not necessarily hesitate when doing IV iron infusions.
Yep.
And at the same time, trying to address his inflammation, as I mentioned earlier. He seems to have not been doing very well with his adalimumab therapy, and he's also failed his prior infliximab therapy. So there's consideration, should he actually be on a different biologic agent? Let's see, help from no levels. When he says that adalimumab helped from December 20...
Just for 2 months.
Okay. But
Yeah.
he otherwise has adequate levels at the moment? Or?
Yeah.
Okay. So in the presence of adequate levels of adalimumab, one wonders whether this actually is helpful. But then the other thing we also have to consider is that, there's also concurrent, the C. difficile infections. Oftentimes it's an interesting dichotomy with between C. difficile infections as well as ulcerative colitis, in the sense that, is a C. difficile in this case kind of one of the bystanders, or something that was incidentally detected, or is it something that's actually also helping to drive the inflammation itself? And some studies have actually shown that concomitant C. difficile infections, and colitis can actually both have a synergistic effect, and that treating both of them concurrently would also be important. There are also studies that show that the use of biologic therapies can sometimes even decrease the risk of redevelopment of C. difficile, and presumably due to helping the maintaining or improving the integrity of the intestinal mucosa. So in this case, I would actually also similar to what Dr. Rubin had mentioned earlier, do the course of vancomycin, in addition to changing the biologic therapy, and in addition to IV iron.
No, that sounds good. So do you agree with adalimumab as his next choice for therapy? So he was on infliximab at first, right? And then he has antibodies, and he's on adalimumab monotherapy now.
So the general message is, if you find a mechanism that's working and then they lose response because of a anti-drug antibody reason, then staying with that mechanism when possible makes sense. And really the only class of therapy where we have those options is anti-TNF. Just a lesson to the room, anti-drug antibodies will cross-react with biosimilars, so don't go to the biosimilar infliximab when you have antibodies against infliximab. I completely agree with adalimumab, but again, I would have done combo because he's already proven that for whatever different reasons he develops antibodies. My only other comment here is that something doesn't quite add up. His hemoglobin's higher than it's been, his stools are soft but not necessarily bloody, and his CRP is nonspecific. So I'd either want a calpro or I'd actually want us to take a look and see what's going on inside to really know what else we're doing. I just learned recently that there's a protein called Ferropour that's related to how we absorb oral iron. So and when you're inflamed, it doesn't really work very well. So I completely agree with what Berkeley said about IV iron in this case.
Okay, so we talked a little bit about, but there was no therapeutic drug monitoring with him. Would that have been helpful to know? Or is it pretty moot point at this point? He wasn't on combination therapy. So as Dr. Rubin has mentioned, his chances, once you form antibodies, there's a higher chance you might
Well, you
form.
have a couple options here. You can. I don't disagree with what Ray has described. I happen to believe it. You either want to make sure you've got enough drug present to not get into trouble with the development of antibodies, or you want to prevent them altogether by having combo therapy on board. One or the other or both, but you want to know what's going on, and you want to be extra careful because you're going to run out of options if you keep burning through your drugs.
Yeah. So Dr. Cross, he has concomitant C. difficile, and he has presumably active colitis. He's going to get a scope.
Well, he has a PCR, right?
Yeah, you're right. It is a PCR. That's true. So how do you navigate this situation?
So I think, in training, you always thought about this, that you were looking for C. diff. You were hoping you found C. diff because that was something you could erase and you could bring them back to their baseline. And I think there are scenarios in the outpatient setting where that's true. In the inpatient, more and more, I think that it's just a marker of a very sick colon, a patient that's very, very high risk for colectomy. I would advocate, I think David was trying to advocate for this as well, that I would do FMTs earlier in IBD patients, and my rationale is I'm not that smart. I would just like to take the C. diff off the table and not have to deal with it, knowing that it's highly effective even in our IBD patients, that I would like to do it sooner. I haven't been able to do that at my institution and convince our fecal transplant provider to do that. In this situation, I don't know if the time course is recurrence or reinfection, but I think you treat for 4 to 5 days with vanco. If the patient's responding beautifully, it's probably C. diff. If not, you're going to escalate their immune suppression after you confirm there's active disease one way or the other through calpro or endoscopy or both. So I think that's what you would do.
Yep, so that's what happened. So he had a vancomycin started, and then his calpro at that time was 950. He said, so this was interesting. So the family thought that all of this was because of C. diff and that they started to question whether he even had IBD. So this is what I'm hearing in retrospect now. So then they stopped his adalimumab and then they started to really focus on the C. difficile issue because they remembered that this is how he first presented. So he had the C. difficile tested again as a PCR test. It's always been a PCR. He was treated again with vancomycin for 2 weeks. Then he was given this for 4 more weeks. And then they started on fidaxomicin, and so he still wasn't clearing the C. difficile. Then he did not want to go on biologic therapy because they thought this is what was causing the C. difficile problem, and then was started on mesalamine aprezo as they were trying to get rid of the C. difficile recurrence. So then he started on fidaxomicin and was actually given bezlotuximab for recurrent C. difficile. Have you seen that being used? So this was what he used. And then he was still on 30 milligrams of prednisone, 8 non-bloody bowel movements a day, 4 nocturnal episodes, and he lost 6 kilograms in 4 months. So for those who don't know, bezlotuximab is an antibody against the C. difficile toxin. Zimplava is the way that it's... so, typically, I haven't seen this used very much, but I thought it was kind of an interesting that this was used first. So what are your thoughts on the C. difficile treatment overall? So fecal transplant wasn't utilized, and I'm not sure if it was because it was, because it wasn't available, but it wasn't something that they considered at the time. But as our panel has discussed, I think this is something that could have been utilized earlier on in the treatment course for this patient. So now he's off of biologic therapy. He's on mesalamine. He's now hospitalized again. He's lost over 30 pounds. So remember, he's presented since 2014, so he hasn't really had very good control. He lost over 30 pounds, and he's now 10 to 12 bowel movements a day, 50% blood in his stool. He's back on prednisone. He comes to the ER, his Tmax is 38.4, heart rate at 130s, blood pressure is 141/99. The ED gives him cefepime and metronidazole because they're concerned for sepsis. This was stopped after 24 hours. And you look at his labs, his white count's elevated, he's anemic, his albumin's a little bit low, but not he's been lower. His CRP is at 5.8, so it's elevated. Iron levels, ferritin are low, and his calprotectin is greater than 1250. He has stool studies done, and all of them are negative. He actually has a toxin assay done. So this is different than the actual PCR. He looks for the toxin. It is detected. So now we have that data. So what should the next considerations in this patient be? He's very ill. He's in the hospital. He has concurrent C. diff with his severe UC. So how would you manage this patient? Is it a no-brainer? What's necessary?
Are you asking what can we do or what should we do?
What should we do?
I think he needs a colectomy. I think just because we have therapy 3, 4, and 5 doesn't mean we should do it. And whether he truly has this really incredibly resistant recurrent C. diff or not, I think he's sick and he needs a colectomy. But I suspect he's not going to accept a colectomy. So then you're probably going to give vanco, inpatient fecal transplant, and then maybe cyclosporin as a bridge to something else, perhaps.
Yeah, so this is what happened. So he had colorectal surgery following the patient. We really wanted him to consider surgical options, and he was not interested, definitely did not want this route. Vancomycin was started 250 milligrams QID. Sigmoidoscopy was performed to rule out CMV. He was started on Solumedrol 20 milligrams Q8. MR enterography was done because his small bowel never was clearly interrogated in the past, so he just had an MRE done in the setting that if he needed surgery. And he was given IV Furlisette during the hospitalization.
And
so this
heparin.
I'm sorry?
Heparin.
And
Sub-Q.
yes, sub-Q heparin, absolutely. That is definitely important for inpatients. So Mayo score is equal 3. He has severe colitis with large denuded confluent ulcerations. His biopsies show chronic colitis with moderate activity and negative for CMV. He has an MR enterography done, and the MR enterography shows diffuse colonic wall thickening with enhancement, mild diffusion restriction, compatible with pancolitis, likely acute on chronic, no small bowel involvement, and no fistulas identified. So what are the different directions that this case can go now? So where can we go? This guy, we want him to go to surgery. He's not interested. He really wants anything but that. And but that is one of the options. Are there any other directions this case can go?
Did he get better with the vancomycin?
He's getting better. We'll go over that. So what are the different options that we can offer him right now? So he's presenting to you like this. We have these data. What do you want to do? He says, no, I don't. I'm not going to surgery. I'm sorry. So what are the different ways we
first
can
of
go?
all, the patient who tells you they want surgery is usually the one who doesn't need it. And this is common, and that doesn't mean you force them to go to surgery, but hopefully the family now understands this isn't just C. diff doing all this. You can consider an induction strategy with a calcineurin inhibitor, which is what we do, and then plan to bridge to vedolizumab as a maintenance therapy. He's very high risk. I would just add that there are some data now that C. diff increases the risk for pouch dysfunction. And we're trying to figure out why that is, probably microbiome or antibiotic related. But so there are issues here that would make you want to think about other treatment options. But honestly, lots of risk factors for badness.
Right. So this is what we were thinking. He's either going to respond to the IV steroids, and we're going to be able to transition him to another agent as an outpatient. He's either not going to respond to the IV steroids, consider cyclosporin, bridge to Vedo or 6-MP, or 3-stage colectomy. So we were going to give him a few days to see how he does on the Vanco with the IV steroids, to see what was going to happen. And, miraculously enough, he does really well with the IV steroids with the vancomycin, very well. So 2-form bowel movements, no nocturnal bowel movements, CRP improves, albumin improves. And so then what do we do with this patient? So would you stop at 3 days, or we continued for 5 days? I believe that we have to continue the steroids a little bit longer than when they start to respond. Is that what you do in your practice as well? So if someone responds by day 3, do you continue the steroids a little bit longer?
I usually just switch them to oral prednisone and watch them another day in the hospital. I usually drop them to 40 milligrams and watch them for a day. But I don't think it's wrong to give them a little bit more IV steroids.
And you don't find that there's a lot of bounce back by
I think for severe colitis, if patients respond, they tend to respond pretty quickly, and it's not usually something you have to scratch your head. If it's those patients that are just sort of trickling along and slowly getting better, they've gone from 12 to 10, those patients aren't responding. But when they respond to infliximab, within a couple of days, they feel well. They're not bleeding. Their stool frequency is much reduced, and this patient had a good response. I think he'll bounce back as you taper him, obviously, but
Yeah.
I think he'd be able to leave the hospital.
Okay, so audience participation, what would you add next for this patient? So he's responded to the IV steroids. He's doing much better. He's on oral steroids. You're going to not leave him like this.
A response is not always enough. So I want to make sure that we're going to actually get him over the top of the hill here. And
so let's wait. Let's see what the audience would do. So let's just do an audience participation real quick.
one of the options here is to continue the IV steroids longer.
He was, yeah.
I'm sorry.
I should have put G other.
That's fine.
Okay. So
What
just
are the
wanted to see what the
numbers?
audience would do here. Okay, so C, majority of you would consider vedolizumab. F would still consider referral to surgery, even though he's having some response to the steroids. Okay, that's interesting.
Jenny, can I just bring up one point with vedolizumab, and it's more a question for the panel. Since he's getting these recurrent C. diff infections, and with vedolizumab, there's a thought that maybe GI infections, there's a risk of increased GI infections. Would there be a consideration here to not put him on Vedo and bridge him from cyclosporin to another, either secukinumab or Tofa?
It's a terrific question. We haven't actually seen a strong signal for that with Vedo. I would actually leave him on Vanco for at least 28 days and try to get him through this entire period. An argument might even be made to leave it a little longer in my practice. But I would keep him on Vanco. I would put him on Vedo. In our system, we have to do it as an outpatient. So that's the other reason I was trying to say I would leave him on the IV steroids a little bit longer, make sure I was getting him where we needed him to go. I like the idea of Vedo. I think that the audience was thoughtful about this. In all fairness, we haven't compared USTA to Vedo to Tofa, but I think that that's not unreasonable. I would have a low threshold to jump to Tofa as my next option for him.
Okay. All right, so he received his first Vedo dose in November of 2018, and he remained on a slow steroid taper, and he remained on vancomycin, actually. We kept him on the whole time. We started also on 6-MP. Is this something you would consider with vedolizumab? Traditionally, patients are given kind of monotherapy for vedolizumab. Do you think that was reasonable or excessive?
I think there's very little utility of Venn diagrams, but I think there are some patients that just need two separate MOAs to control their disease. So I think if you feel that this is the last chance you have to save him from a colectomy, it's not unreasonable to add a second mechanism. I don't think you need it for immunogenicity. It may also increase drug levels of vedolizumab, and clearly drug levels, if you look at his history, have been a problem, either that or early antibodies. So I don't think it's unreasonable to do that in your third biologic class to add something else as well.
So I agree, it's a knowledge gap regarding whether veto patients will have an increased risk of antibodies after patients have had antibodies to anti-TNF, and you don't want to take a chance here. And we knew his TPMT was intermediate or something like that. Normal, 17. So then use a little higher dose maybe, but it looks like you got enough 6-TG there based on the retrospective study that Maria Abreu did. Maybe you were on that. So you want the 6-TG to be over a 125 if you're using it in combo therapy in their analysis to prevent antibody formation. So I think it's fine to have done that.
Yep. So I actually wanted to, since this guy was so refractory, we did try to get the 6MP to a more therapeutic 6-TG level, just because we weren't sure if he was going to actually respond to the vedolizumab yet. So he was on prednisone 20 milligrams. And then we did check a week 6 vedolizumab level because he was so tenuous, and his level comes back at week 6 at 7. Yeah. So, so what do you think? Is the vedolizumab working for him? Was the level useful for him to? So this is a real case, so it's actually real data. So I mean, his level came back pretty low. So is the vedolizumab working for him? And what changes would you make, and would you just hang tight?
So I'll tell you what I would do and what I should do. So what I would do is give him his next dose at week 10 and check his level again. But I suspect that that's not going to get you to 14 or above. And I think probably looking at this profile, David mentioned having a low threshold to go to Tofacitinib. I don't think he's just not going to respond to a biologic. He just clears everything rapidly. I think probably what should happen is he should just go to Tofacitinib. But what I would do in clinical practice, you've already started the drug, he's not doing terrible, I would probably take him to Q4 maintenance right away, assuming you can get that from the payer.
Okay, so he does go to vedolizumab every 4 weeks. We did request a Calpro, he doesn't return that back. We were tapering the prednisone by 2.5 milligrams each week. So we kind of discussed whether we would switch or hang tight. So we're going to hang tight for a little bit longer. Do you think the 6MP is helpful? I personally felt that at this point it would be helpful since we weren't going to be clear if he was going to clear the drug quickly. And then how slow do you taper prednisone with the vedolizumab transition? And, so we know that the onset of action for the vedolizumab can be a little bit slower. So do you usually do you keep the prednisone on until week 14 in patients like this, or how do you manage the prednisone?
When I have people on prednisone and I start veto, I do a fecal calprotectin at week 6, actually, to see that they're going in the right direction, and I start getting them off steroids right away. They're done with steroids by week 8. Okay.
All right. So we were going to consider a fecal transplant on this patient right away. But we were unable to do that due to some approval delays. And by March of 2019, he felt that his stools were becoming more loose again, and he started to see blood when he was down to 5 milligrams of prednisone. And he's actually still on vancomycin. Actually, I'm sorry, he's off of vancomycin at this time. His fecal calprotectin's at 1402. His CRP's at 5.7. You get a C. diff again, a PCR, and it's positive again. So you start him back on the vancomycin, and you increase the prednisone at 20. You ask the patient to start Shingrix because we are thinking about changing mechanism of action. So you get the Shingrix vaccine started, fasting lipid panel. So what would you do next in this patient?
Well, a third of the audience is saying, see, I told you. And when we do Shingrix, by the way, we usually do it after they've already started Tofacitinib. You can give it after the patient's on therapy. Remember what I said, that the risk doesn't go up much until you've been on drug for 8 weeks or more. So you have a little time to get the drug started And I can tell you right now, his fasting lipid panel at baseline is going to be low. In fact, even in the label, they don't recommend a baseline lipid panel. Not that I'm saying you should do that. I'm just saying that it usually doesn't change anything. You do one after a month of being on therapy.
Okay. So you perform a sigmoidoscopy because you finally get the FMT approved. And actually, it looks much better. So he's had mild endoscopic improvement. He does have the pseudopolyps present, but there's patchy erythema still present. But compared to what you saw in that last colonoscopy, it actually looks much better.
But his Calpro was 1,200?
It was 1,200, though. It was. And that's another question I have for the panel. Do you see with pseudopolyposis that not to the level that we're seeing, but can it be that elevated?
Maybe, but again, we know that Calpros like that are predicting a problem. So
exactly.
You may see things look better, and I agree. I just would be nervous and want to push him a little bit more.
Exactly. So that was disconcerting, but we did see there was some improvement here. So he did well after the FMT until the prednisone was off. And at that point, then he started saying his symptoms were increasing. So 8 bowel movements a day, greater than 50% of his stools with blood present. At this point, he's on 22 weeks of vedolizumab. He's had 2 doses at every 4 weeks. Again, his C. diff toxin B is positive again. Hemoglobin's at 12. His calprotectin urecheck is at 2,000. So is this the recurrent C. diff, or is this uncontrolled UC contributing to this current flare, and now what would we do?
It doesn't matter so much.
Yeah, you're right. It doesn't matter at this point.
He still hasn't had a fecal transplant, yes?
Oh, he
Or
did have it.
it.
He did have it. Mm-hmm.
Well, let me just say that in ulcerative colitis, the cure rate of C. diff with fecal transplants is less than in the non-IBD population. It's only about 70%. So some have said you need to do 2 transplants to get rid of the C. diff.
Mm-hmm. Right, that's important. So anyway, he completed his Shingrix vaccine series. 6-MP at 100 milligrams had already been started, and he wanted to continue and add a second agent. Since he had that initial response to infliximab, we decided, and he had mild endoscopic improvement, and because he's still refusing surgery, despite meeting with surgery and discussing those options, we added golimumab to a 6-MP, and a steroid taper was started again. And this time, his instructions was to stay on vancomycin, and he stayed on it for several months. So he's been on it for several months. We discussed already tofacitinib as the next line agent if the golimumab 6-MP failed. So he's been off of steroids for 4 months, and he's been on golimumab 100 milligrams every month with 6-MP at 100 milligrams. He remains on vancomycin until 2 days before his colonoscopy. He has extensive pseudopolyposis. His Mayo score is 1, though, and FMT is performed at this time. So he remains on vancomycin for about those 4-month period of time while he's on the golimumab and 6-MP, and he actually feels pretty well. And when you look at all his labs, you see that his calprotectin has diminished down to 193. You see that his 6-TG is in the therapeutic range at 329 right now. So at this point, his thiopurine metabolites are in therapeutic range. His calprotectin has improved, and his symptoms have improved. His iron deficiency also has improved, is still there, so you give him an iron infusion. So he's stable. Do you think this is working?
Sure.
Yeah. Yeah, so I start to get really excited. So, I mean, it seems to be working. So you still monitor him. He's now having 1 to 2 bowel movements a day. He's normalized his CRP, and his anemia has improved. You've asked him for a calprotectin, but he doesn't get that for you. So right now, that's where we're at. Just a few questions for him. He's a young male on 6-MP and golimumab. So, I mean, he barely got through this whole process. And now, we talked a little bit about EBV. Dr. Rezapour did. Do you check EBV on all patients that are starting 6-MP? Do you all do that in your practice?
No.
No.
If they're over 21, there's a 99% chance they already have EBV, and I don't. I also use more methotrexate as my combo therapy of choice.
Mm-hmm. Okay, so yeah, I haven't been checking it either, but it is something that I do wonder, if we have to consider worrying about, and it sometimes does come up with him, especially since he seems to be therapeutic on. I think the 6-MP was an important part of his therapy.
It's not wrong.
Mm-hmm.
It's not wrong to check it. The rationale being if you're negative and then you get EBV on 6-MP, you get hemophagocytic syndrome, which is awful. And I think checking it depends on whether you've seen that in your practice.
Mm-hmm.
And so I have been fortunate to not see that. And I don't think you should mess with this guy's meds at all. I think you finally got him to a point where he's okay, and his meds shouldn't be changed for a long, long time, if ever, in my opinion.
Right. So he has now extensive pseudopolyposis. What are you going to do about his dysplasia surveillance? So, Dr. Rubin, what are some of your thoughts on his dysplasia surveillance?
Well, the traditional teaching is that pseudopolyps are an independent risk factor for dysplasia. And now there's a more recent paper that Steve Itzkowitz from Mount Sinai was a senior person on that suggests they may not be. So whether you agree that they're a marker of dysplasia because they're a marker of previous severe inflammation or not, the practical challenge is that it limits your ability to see things as well as you might have wanted to. So the truth is that when you have carpeting of thousands of pseudopolyps, it is hard to actually do adequate surveillance. And you have to communicate that to the patient and document that you can't perform adequate surveillance if you can't see everything. When there's scattered pseudopolyps and you're more comfortable, you can flip on narrowband imaging and take a look at these and usually tell that their pit pattern looks identical to the flat mucosa surrounding them. And so most of the time you can figure out what that is. There's a distinction between a pseudopolyp, which is a healed mucosal raised lesion that looks like a little worm or even bridging pseudopolyps, and an inflammatory polyp, which has a more of a hemorrhagic appearance or an exudative surface. Those are distinct, but both are not dysplastic. So if you can't see everything, the traditional recommendation would be that you say, I can't perform adequate surveillance and you should have surgery. Nobody ever takes you up on that. So then you're left doing non-targeted biopsies and trying to do the best you can and leaving them on a more of an active surveillance plan of more intensive follow-up.
So I'm going to just touch briefly on your dysplasia surveillance practices. Are you doing chromoendoscopy on all your cases?
If by chromo you mean using color to see better, the answer is yes, but I'm using narrowband imaging now almost always. Okay. I use scattered and selective dye spray for very specific lesions and areas.
Dr. Cross?
So I only do indigo carmine for the prior dysplasia patients and the PSC patients. I have been trying to do more narrow band for the lower risk patients, and frankly, it just depends on time. Mm-hmm. If I'm on time, I'll go ahead and do a second pass with the narrow band. If I'm hopelessly behind, I just do a slow, careful HD white light exam with 10 to 12 biopsies throughout the colon. I don't do the 30 random biopsies plus the targeted. It's not terribly effective, and it's just not time efficient either.
A quick question. In a court of law, would we be okay if we didn't do the 33 biopsies? You know, if someone did have...
Yes.
We'd be fine. Okay.
I mean, do a careful exam, keep your eyes open, target things that look unusual. If the prep is bad, if they're inflamed, or if you can't see everything, you document it, you bring them back more often. Mm-hmm. But you can call me, I'll help you.
And then Dr. Limketkai and Dr. Rezapour, what are you doing for your dysplasia surveillance practices?
Yeah, actually, I currently use a chromoendoscopy with methylene blue as well. But
for all your cases, or selective cases?
For most cases. I mean, I guess maybe NBI is much easier, so maybe I'll actually transition to that after hearing what Dr. Rubin had mentioned. But then for those there are certain select cases, particularly those where you had mentioned about extensive pseudopolyps, or in whom those I think that there's maybe still some active inflammation where I do more biopsies.
I use Chrome only in high-risk individuals, and then NBI with targeted.
And then NBI you're doing targeted, right? So you're switching to NBI and looking at the lesions that seem suspect. Okay, very good, thank you. So yes, we talked a little, Dr. Cross talked about this. If he had a flare again, so if he has a flare again, what would you consider? Would you insist on surgery at that time?
I would have had him on Tofa at this point in my practice. I'm delighted he's doing well, and it proves the point that the TNF mechanism did work if you can just keep him on it and protect him. So you did the right thing, but I would be still willing to consider Tofacitinib.
Okay, this was the rest of the question that I was going to direct towards Dr. Cross. So you would not de-escalate this patient ever, right? I think I agree with you.
I would hope he would
He's
go to
already
USC
asking,
instead
so.
and do that.
Okay, so take-home messages. If there are high-risk features, treat early upfront with an aggressive top-down strategy. And if patients have failed multiple therapies, you need to plan and counsel the patients early on various avenues of therapeutic plans of action. And in patients with high inflammatory burden, therapeutic drug monitoring relative to the inflammatory burden and can help to optimize medications or alter your treatment course. And in recurrent Clostridioides difficile infection with UC flare, both the disease activity needs to be treated and the infection need to be controlled to break the cycle. So I think that Dr. Rubin's point of holding on to that vanco for longer, I actually think that strategy is very important in these type of patients.